So good morning and welcome to Melanie and Boon. We are here for round two of our very privileged, I think, little get together that we've got here running for the Facebook group, Yoga and Meditation for Gentle COVID Recovery. And our incredibly informed and inquisitive members have put together yet another round of questions for you to experiment with as we go through the next hour or so. We're going to jump right in at the deep end. And I'm just going to read what I've written here because it's really early in the morning and it helps me to read and make sure I'm asking the right thing. So Mcas, mast cell activation syndrome, this became something that we were talking about as people with long COVID last year. And many people kind of jumped on the bandwagon because we really wanted to try things to help ourselves when we weren't really being offered much other stuff to work with. So Mcas has quite an intense protocol around it, which involves changes to diet, taking supplements like flushing niacin, very specifically antihistamines B1, B2, plus many other things. It's pretty tough and it can be at times quite joyless when you're not feeling well and all of the food you want to eat, you can't eat, etc., etc. What we know is dysautonomia causes a deregulation of the autonomic nervous system, right? Could this also be triggering Mcas in some people? And an overproduction of histamine. How do we work out what is Mcas and what's dysautonomia so that some people could potentially free themselves from some of the elements of the regime or not? I don't know. We need your help. So Boon, I'm going to come to you first with that one.
Good morning, Susie, and thank you for the phenomenally detailed question, which has at least 4 components in it. So it will take a bit of unpacking, but I'm happy to try and do that as succinctly as I can. So Mcas, or mast cell activation syndrome, is due to the fact that your cells, some of your white cells, which are mast cells, so we've heard of neutrophils, lymphocytes, macrophages, these are like the Pac-Man cells that come and gobble up any pathogens or viruses and bacteria. The histamine-containing cells are called mast cells, and they can degranulate. Degranulation of a mast cell releases a very sudden, abrupt increase in histamine. So let me give you an example. If you have a bee sting on your hand and it immediately wheals or immediately gives you a allergic reaction, what is coming into that site is a mast cell that is releasing its whole content of histamines into that area. Now, histamines in themselves are the things that make your membrane, so as far as long COVID is concerned, they make your membrane permeability increase. What that means is that the blood vessels become leaky. And when the blood vessels are leaky, what can happen is the white cells can penetrate that blood vessels to get into the site to take away the bee venom or the toxins from the wasp sting. So we see this, and that's an example of why we have histamines and why histamines are helpful, because they help to mobilize the immune system army to the site to get rid of stuff. Now that's stage 1. Stage 2 to unpack is we know, and I know because my daughter has it annoyingly, that some people have chronic idiopathic urticaria. Now this is a condition that is characterized by sudden wheals without any particular triggers. And those of you in your group who are listening, some of you would have had this in the past because it affects probably 1% of the population, particularly in childhood. And these are when your mast cells are slightly unstable and they suddenly degranulate for some unknown reason. It turns out that those unknown reasons could now be looked into and actually are very sporadic. So just like in the last week when I talked about what it makes for somebody to faint, which are a number of factors coming in together at the same time, it is not the case, again, with mast cell degranulation for somebody with chronic idiopathic urticaria to have a specific response whenever they eat tomatoes, for example, or whenever they're exposed to some pathogen like pollen. That is not the way it works. The way it works, it appears completely randomly, like I've seen in my daughter. And what happens is that with time, it's worked out on itself. But actually, one of the common themes I've seen is stress. And actually, when you have stress, stress itself and probably mediated by adrenaline sensitivity, because when you're in a stressed out state, you have high amounts of adrenaline. Adrenaline sensitizes mast cells. Think about it evolutionarily. You are about to fight or fright with a tiger. Your adrenaline levels are up. You get a scratch. You need to mobilize very quickly your immune army to fight and close off that scratch, because you've been hurt. And this adrenaline heightened state primes the immune system to go into overdrive, yes? So I want you to take that as step 3, which is when you have a heightened level of stress or reactive immune system, you are more likely to degranulate. So that's stage 3. And stage 4, what we talked about last week, is what is long COVID. Long COVID, from an autonomic dysfunction viewpoint, is when there is an imbalance in the fight or flight or stress response versus the rest and digest response. So guess what? Your immune system army is primed to attack. And in fact, that's what it's doing. It's attacking your joints. It's causing inflammation in your fingers. It's causing the arthritides or painful joints. It's causing you to be always on high alert because of the high adrenaline. And it's causing your mast cells to become likely to spontaneously degranulate. So step 5, sorry to go on in this way, is that when you have a high adrenaline levels, randomly, particularly in my experience now at night, when your pressure drops as it naturally does when you're lying down, your mast cells will get to a point where critically they may degranulate. And this is my current working theory and hypothesis, and something I'm working with Mel to study in a research grant that we've submitted to NHLI, to see whether or not we can look for evidence of this mast cell degranulation, which is quite difficult to find. You need to do a fairly rapid blood test and a urine collection to measure what's called the serum tryptase level. And when we find that, we know that that theory is correct. That is, the reason you wake up suddenly at night with palpitations, feeling bothered, feeling sweaty, is because your mast cells have degranulate. Where? Everywhere, particularly in the inner organs like the spleen, the stomach, the liver, the lower limbs. And what that does is it makes your vessels, remember I said, make it permeable and dilate. So your vessels are dilating. And what happens when your vessels dilate? You take blood away from the core circulation, your heart and your brain. You park it into your abdomen, your lower limb, even when you're sleeping. And then the blood pressure drops and drops, and then you critically have an adrenaline response to try and combat that blood pressure response, the blood pressure drop. And then you wake up because the adrenaline surge causes you to have the palpitations and the feeling that you can't catch your breath. So anyway, that is the physiology in a nutshell, okay? Sorry, it's 5 stages, but boom. Now we come to the stage where what role or what therapeutic strategies can we now deploy if we think this is going on? And I must say that I haven't deployed flushing niacin, although my patients have been on that, but I have tried antihistamines. And actually the antihistamine groups, and the one that I use is probably a combination of a H1, histamine receptor type 1, and a H2 receptor. The combination of that is quite useful, but I tend to use a non-sedating antihistamine in the morning and a sedating antihistamine in the evening. That would be my preference. So something like fexofenadine, loratadine, or cetirizine in the morning, and then something like ketotifen or Piriton in the evening. And that somehow stabilizes the patients, or in those patients in which mast cells are a dominant part of the symptom profile, they just feel wound down by kind of 3 steps. And here before the interview, you shared with us your own experience, Susie. And I wonder whether I can now ask you to share what is it you felt when you started to take those antihistamines that were prescribed?
So they were prescribed to me because I was having trouble staying asleep for more than an hour. And my body, I could feel my body just declining rapidly. And my doctor had tried me on sleeping tablets and then doubled the dose even, but that hadn't touched the sides. This was such a strong set of symptoms. And so they put me on an antihistamine. They said, we often give these to the elderly to help them when they can't sleep. And it was such a game changer for me. Not only did I have my first night's sleep in about maybe 9-10 weeks. When I say first night sleep, I think I slept for about 5 hours, which was a gift. But I also started to notice that I felt like a fire had gone out in my body. Something had changed. And I know particularly in my foot, which was having all sorts of kind of cut with COVID foot, whatever that is. But, you know, skin changes and a kind of swelling and a pressure, and, you know, my skin was kind of peeling off my foot. And suddenly all of the pain went from that. And I thought, oh, well, this is good. Whatever this is, I'm not stopping.
So in my mind, that is a very low-hanging fruit. The antihistamines are cheap, they're readily available from pharmacists, and actually, I don't think there is much harm in having a trial of it, let's say for a week, because if it makes a difference, as you said, it could be a game changer.
Yeah.
So don't wait to see me or Mel or any other of your long COVID specialists, because if you feel that what I've said resonates with some of your symptoms, there's no harm in trying some of the over-the-counter antihistamines for a week or two and see whether that can quell the fires of the sympathetic surge. It's
I
not
think,
really an
can I just say that
anti-symptom.
I think a lot of people are taking them. So when I asked my group, my live group of about 50 people recently, I said, just wave your hand at me if you're taking antihistamines. I would say about 97% of that group waved their hands. But interestingly, they were taking them for different things. So, you know, some people said, we're taking it for the fatigue, we're taking it for the skin, we're taking it for the shortness of breath, but all of them were taking them definitely, because it's part of the kit now. Whether or not you understand why, you just take it.
Well, I hope the explanation has given
I
a
think
bit
it's
more of a
brilliant.
physiological understanding. And then there's another question that was related to that. How do we work out what is Mcas and what is dysautonomia, so that some people could potentially free themselves from the elements of this regime? And by this regime, I think taking a pill twice a day is a very simple regime. Taking a low histamine diet is a very, very tough protocol. I've tried it myself, or I've tried to do it for my daughter. It's very tough. And actually, I think the bang for buck in terms of the amount of benefit that you would get from taking a regular antihistamine in terms of magnitude will be far above and beyond trying a low histamine diet. So if you want to try, but try it for a week. And if it doesn't make a difference, then don't torture yourself and continue with that. So we have an open mind. And then the other thing to say is this is long COVID. By definition, it hasn't been around very long, i.e. 6 months to a year, which means that how do we know as research experts, us, because we haven't done the trials. And guess what? Research experts are very, very afraid to take the step into the unknown in terms of recommendation. Why? Because we're not evidence-based yet. Evidence-based means the scientific process by which we conduct a double-blind, randomized, placebo-controlled trial. All those words mean that the trial will need to be done in a number of patients who are all participating blinded to a therapy. And we simply haven't had time in this very short illness process to conduct those kind of trials. But this anecdotal experiences and what we can speculate based on sound physiological principles can still be applied for the improvement of individual patients. And that's what you're reporting to us. And that's what my patients are reporting to me. Am I going to let a lack of data help me in this process? No. And I think just getting patients to understand that we don't know whether it'll work or not because we haven't seen the trial, but there's a physiological basis and there's a trial period with little harm means that we can let these patients try.
As a small disclaimer, I'll just say that if you're older, and by that I would say sort of over 70, all of the above applies, but probably just talk to your doctor about it, because sometimes if you're older, and particularly if you've got some memory problems, these medications can cause side effects, and you shouldn't take them long term. Just a small disclaimer. And so again, it's risks and benefits. If it helps these intractable side effects, then it's fine to do it, but just be aware that there can be side effects for older people.
Yeah. Okay, that's really worth knowing. Thanks, Mel. And so let me just get clarity. If people aren't noticing, if they've gone on and started this low histamine diet and it's not making any difference, even within the first week, you think that's time to call it a day. They should have noticed a difference, you think? Yeah.
I don't know what the time is. I would say anything between 1 and 2 weeks if you really want to give it a go. Give it a go, but change one variable at a time. So for example, do not start the diet and start your antihistamines on the same day, because then you'll think that the diet is doing it when actually the majority of the effect is from the antihistamines.
Right.
So in medicine, we say change one thing at a time and give it time to work, i.e. a week or two before you stop taking a drug or a diet that you think hasn't worked and trying the next thing.
Great. Great. That's really helpful, because it's definitely a big part of the conversation, and how people are beginning to try to help themselves. So this really gives us some good guidance. Thank you, folks. Okay, we're going to move on to a little bit more detail around the dysautonomia phenomena. So I want to talk a little bit more about it, because I think so many people are amazed at the breadth of symptom list that we've begun to kind of collect. I'm just going to read them out so that I feel like, those people that shared some of their symptoms feel that they've been heard, because actually, often if you took this to your GP, they'd go, what? So forgetting to breathe, that sensation of forgetting to breathe, burning sensations, excessive sweating, shortness of breath, tremors, post-exertional malaise, brain fog, muscle spasms and twitches, loss of taste, anxiety, coughing and phlegm production in the throat constantly, headaches, burning chest pain, bedtime heart racing, fever, rushing heartbeat sounds in ears, body temperature dysregulation, so very low. So a lot of people talk about being cold, and I was definitely one of those. Edema, fatigue, insomnia, the loss of smell. Oh, you're sharing a screen, great. Increased heart rate after exercise or eating a meal, muscle weakness, and a lot of people are talking about pain in their legs if they do anything like a little walk, and increased muscle pains after very mild exercise, yes. Are all of these possible signs of a dysregulated autonomic nervous system?
Mel, do you want to take this?
Yes, yeah, and then we can use your diagram as a prompt. So yeah, I mean, these are again great questions from the group, and all of these symptoms are symptoms of long COVID, which is quite commonly. With respect to the autonomic nervous system, most of them are, and we'll just go through them in detail. And if you remember from last week, we had a look at this diagram which shows the effects. And obviously when we talk about the autonomic nervous system, we tend to think about the symptoms of dizziness on standing and low blood pressure on standing. But going back to that description of the physiology that Boon was describing last week, when you stand up and the blood pools in your lower body and there's a lack of blood getting to the heart, which then reacts by beating faster and stimulating the fight or flight response, or the sympathetic nervous system, it leads to an increase in the noradrenaline, so the stress response. And so a lot of the symptoms can come from that. So the symptoms here, we've got excessive sweating, so temperature dysregulation, that's a sign of the autonomic nervous system. Shortness of breath, because the sensation when of lack of blood getting to the heart, so your heart beating faster. Tremors is the sense of the is quite common, and we see that in POTS as well, and orthostatic intolerance syndromes, and that's again the effects of the noradrenaline in the system. Brain fog we talked about in detail, yes, as well. Post-exertional malaise, so after exercising, coming back and feeling disproportionately exhausted, or not even after exercising, but after getting up and going to the toilet or whatever. And yes, and that goes back to this sense of this chronic and disabling fatigue, particularly related to exertion. And it is very common in long COVID, but it's also very common in autonomic dysfunction. It's because, again, your body is working much harder than it should be, even for doing things like standing up and going to the toilet. Chest pains and bedtime heart racings, yes. Temperature dysregulation in your body. So your again, the autonomic nervous system does control your temperature. So if it becomes slightly impaired, then you can feel either very hot or very cold. That all relates to the fatigue and the lack of sleep at night, and the increased heart rate after exercise. So a lot of this, the thing I would say is loss of taste and loss of smell. These are specific symptoms of COVID. Again, we're not quite sure why it happens, but it's probably related to the COVID itself rather than the autonomic nervous system. I don't know, Boon, what you think about that. Edema is referred to is swelling in the subcutaneous tissues, so underneath the skin. I don't know, I can't think why that would relate to autonomic dysfunction per se. If it is, if you are noticing that you're getting significant leg swelling, and particularly if you put your finger over your shin bone and it leaves a dent, that might be a suggestion that there's something more than autonomic dysfunction, that you should see your doctor. And I think there's probably worth thinking about a couple of the symptoms of COVID and some of the post-COVID complications that are separate from autonomic dysfunction that could need further investigations. And I'd say
so Mel, I'll step in there and just say that there is a phenomena of joint inflammation, aches and pains, but this tend to be very localized to a particular joint or the digital or the fingertips or the toes, and this kind of rheumatological immune response activation may well be the syndrome, I think, of long COVID. But what Mel is talking about is absolutely right. If you have bilateral, that means both legs swelling to the knees, and you can press on your shin and see an indent, like you've been taking a long haul flight for 14 hours and you get that kind of similar swelling all the time, then it's worth seeing your doctor to ask potentially whether or not there is a problem with fluid congestion from a heart that's affected by COVID directly. So not long COVID, but a cardiac complication of COVID.
Okay.
And similarly, if it's just one leg that's swollen, again, there are other complications from COVID, most sort of commonly blood clots. So a leg that becomes swollen, particularly tense or very painful or very red, that is a sign to get urgent medical treatment.
Mm.
So I will say that I will share an article with you, Susie, for you to put in the Facebook group. This is freely available, and that article, just let me share it with you now, is called Characterizing Long COVID in an International Cohort. And this is the kind of research which is done via a survey. I think you can see it on my screen. And it's a survey that was done on a good number of patients, 3,762 patients from 56 countries. And quite, I think you're seeing me click down on here. Quite impressively, you can see that all these symptoms are described. A lot of the symptoms that you've just highlighted to us are described entirely in the survey. And one of the major speculations at the end of this, and this is quite an easy read, I would say, is not written in a way that is too technical, because it's literally a symptom profile description. But you can see that so many organ symptoms are described. So as I click through very quickly, I know the people watching are not going to be getting this straight away, but I'll send you the link to this that you can highlight. But I guess what I wanted to click to is to say that at the end of the day, the survey discussion talks about the fact that there is dysautonomia, in part manifesting as POTS, and MECSF appear as highly possible diagnosis for this population. So that is the key point that I want to bring across, which is the long COVID cohort of symptom profile fit or are most in keeping with this kind of trio of POTS, ME, CFS, which is the results of the survey. And of course, with the caveats that we will talk about red flags and what to consider to make you not having long COVID, but a direct complication as a result of POTS. For example, if POTS has caused a severe myocarditis or severe lung damage directly. So I'll come off the survey, but I'll send you the link, Susie.
Brilliant, thank you. And I can put that in at the bottom of the YouTube video. Okay, so this next question actually really interests me too. Once you have worked to stabilize the autonomic nervous system, how sensitive is it likely to be looking forward? So someone is saying here, my job is quite stressful and I'm worried that it might be forever going to be triggering mini relapses. A lot of people have that question of, can I go back to who I was? What do we think?
I don't mind taking this on, Mel. It's quite it's quite an interesting one to discuss, and the honest answer is change your mindset. And the reason I'm saying that is that in day-to-day life we will have knocks, and even even a person who's fit and healthy will have days. For example, I've come off a really tough week and I'm not normally stressed, but because of the tough week with long hours, with multiple different clinical and non-clinical work, I've developed a mouth ulcer just here. So it's painful as hell. And we know, and I know that if I just have 2 nights of 5 hours sleep and I'm a bit agitated, then I get a mouth ulcer. So if I was just looking from the lens of a painful mouth ulcer and I said to myself, can I lead life without ever getting another mouth ulcer, i.e., can I not be in this situation again? I can't reliably say that I can, but what I can do is I can be aware. So this awareness is very helpful because I now know why I had the mouth ulcer, because I took on too much, or because I have had a long, difficult week with many, many meetings after hours. And this experience has taught me to be aware of what can trigger a relapse in my mouth ulcers. So I'm giving you a very specific example in somebody who's apparently healthy, but with somebody who has the susceptibility to low blood pressures. So I see a lot of patients with vasovagal syncope. And the reason I'm talking about this is because I know vasovagal syncope very well. And patients often ask, will I never faint again? And the answer is, I can't say you won't. Because if all those things line up in a row, if you go on a hen night or if you go on a very extended kind of weekend road trip, or your business means that you, or your work commitments mean that you have 5 nights on the trot, that you're working into 1 hour, into 1 or 2 a.m. and sleeping very little, or you have a young child who's keeping you awake, you will have vasovagal syncope. So guess what? The answer to your question is that if you switch your mindset and you're aware about your triggers, then when it hits you, don't be surprised and don't be so hard on yourself, because I have a ulcer that hurts now, but I'm not angry at myself. I'm just aware that the reason I got it was because I allowed myself to get into a situation. Now, would I do it again? Yes, I would, because those commitments just needed to be done. But this week, I'm going to have an easier week before another week that's very tough next week. And I know I might get a mouth ulcer in 3 weeks' time. So it depends on your quality of, I guess, mindset. And if you are aware and anticipating that your job is going to be stressful and going to potentially trigger a mini relapse, then guess what? Be prepared for it and don't beat yourself up when you do have a mini relapse. Feel good about yourself. The best analogy, another analogy is if you go out drinking and you enjoy the night, guess what? The next day, you might have a hangover. And guess what? Is the hangover worthwhile? Well, it might be because you enjoyed the night previously. And if the hangover keeps happening, then do you change your drinking habit? Yes, you might. So do you change your working habit? Do you change your job? Do you say to your boss that I want to work less hours? What needs to change is your mindset. So then you say, do I need to earn, can I afford to earn less money, live in this environment, this house, not pursue my ambitions, but actually maintain my health? These are important questions that go beyond the simple, will my health get worse or better? It just all feeds into your day-to-day work-life health balance.
Yeah, and being mindful that you have a susceptibility
Right.
is actually very helpful.
I think one of the things I see often commented in the Facebook group is having COVID has taught people that they need to look after themselves. We're not superhuman beings, you know, and despite thinking that we might be for a lot of the time, we aren't. And, you know, if there's one thing that has come as a sort of a gift, if you can say it like that, it's actually to treat ourselves with more respect.
Yes, and self-care is a necessity. It's not a luxury, and often the modern ways of living make it a luxury. And so just being mindful of that can actually help, and realizing the things you need to avoid stress that within our control.
I think this is a great point to segue into what you were saying to us earlier on, Susie. You have a very interesting perspective, and I want to ask you, Susie, because you said words that would be really very shocking to hear, which is you had long COVID yourself and you were suffering. And did you say that you felt it was a gift?
Probably not at the time, but yes, I do now look at it as a gift that it's given me for lots of reasons. In some way, I was sort of in a point in my career where I knew I wanted another kind of creative revolution to occur for myself. I wanted something that brought my skills, my interests together. And then I got sick. And I sort of didn't know that it was going to be the COVID bit that was the gift. But, you know, I lay in bed and thought, okay, so I've got this thing, and this thing is now a thing for thousands of other people. And maybe I could reach out and connect and help people on their recovery as I kind of experiment with my own. And then I realized really quickly, oh, there's not too many people doing what I've just done. And that feels good. And I realized that that felt good for me. And that meant that I didn't lose my way in, you know, in life, I suppose. In some ways, it almost focused me into a truer seam. And so I look at it absolutely now with gratitude, because it's taught me to focus back on my own health. So actually, I made some pretty big decisions about my life last year, and made some really significant changes. And I'm still kind of bringing those to fruition. And I've connected with people that I would never have met. And I found a purpose that I didn't realize was as important to me as this now is. So without actually having caught COVID, none of this would have happened. So I look back at that point where I sat on my bed in March and went, I think I've got COVID, and go, good. You know, and I know there's going to be people listening to this going, that is not my story. And I totally get that, you know, because not everyone, there were people who were absolutely in the prime place for themselves, you know, really happy with their jobs, really happy in their relationships, really happy with how things were. And now this has come along and changed that for them. But I took it as an offer. I took it as, you know, what can I do with this rather than be broken by it? How can I weave it into my fabric so that it becomes something that I can be creative with rather than crushed by, I suppose.
That's a fantastic story to share. And I just want to pick up on the point that both of you have raised is actually the patient that comes into my clinic that I know will do well, embraces the physiology and actually gets the mindset, and doesn't necessarily say to me, doctor, how can you make me better? What can you do for me? What can you, what diagnostic tests can you run? And what tablets do I need to take from you? Because that is externalizing the issue. Whereas the both of you said, if you gain education, you're empowered, you have an expectation of recovery, a self-expectation, and then you execute on those plans to help yourself to improve. You have a much better chance of healing with the doctor just playing, or the healthcare professional, or in fact not seeing anyone at all, just playing a sideline role, just to guide you. But you have it within you, or you know, everyone watching this has it within them to make a mindset shift. Now that can be done for free. That can be done after this webinar. That you shift yourself to mindset, and you express this very, very important emotion that is known to down-regulate the sympathetic nervous system. And I didn't prompt Susie to say this, she said it herself. What was that emotion or that feeling? It was gratitude. And we know now that gratitude is one of the most empowering, vagal-inducing emotions. As opposed to fear and anxiety, you have gratitude and then compassion, love, and very strangely, forgiveness. And forgive yourself and forgive everyone around you. Forgive your doctors for not knowing how to treat you. These constellation of emotions will down-regulate your sympathetic nervous system and up-regulate vagus. And if you can do that, coupled with a bit of breath work, which I hope we'll have time to show today, the breath work plus the emotional states can really, really help allow your mindset to shift gently to a more positive vagal mindset rather than a reactive, triggered mindset that somebody with a high level of adrenaline or stress has. So very important concepts that have been raised that I've just kind of picked up and expanded upon.
God, it's so interesting, isn't it? When especially when we hear someone with, you know, all of the medical background that you guys both have, talking about this stuff, because often this is the realm of kind of psychologists and yoga teachers and therapists, you know, they're looking at the impact psychologically, but to hear you talking about that and saying, actually, this is real medicine as well. Because I think there's so many people who are sitting there waiting, well, what's the drug that I can take? What's the drug? Come on, you guys must know, you're holding it back from me. And there isn't one often, you know, unless there is a really clear specific need for someone to be on a particular medication. And that's often really frustrating for people.
So, I mean, you got me slightly inflamed now, but we have within our capacity to produce drugs. When you go for a run, you get your endorphin load. That is the strongest painkiller that you can ever have. When your whatever child is under threat, you can go and do superhuman things that you can never do, because the adrenaline primes your system for feats of superhuman strength. I mean, not lifting a whole building like Superman, but you know, you can do a lot more than you thought you can.
Yeah.
Likewise, serotonin or all these neurochemicals in your brain can be, or oxytocin, the love hormone, the connecting, the bonding hormone. These are things that you can express through a change in your thought. Can you imagine that? You have the best pharmacy. Where does it sit? Here.
Yeah.
In this wonderful body that you have. Now, you don't need to go to Pfizer or Astra or ask any of these big pharmas or your doctor to say, prescribe me something. No, you don't. You have it within yourself. And you might not have seen it or reached for it for a long, long time, nor feel capable. But this is the time that you reach in, not reach out. You reach in to heal, and it is possible to heal. You need to start by believing that you can.
Loving that. Really, really love that. And I know it's controversial, and some people will go, oh, but I have tried. And it's about how you try and how that you keep trying.
Susie, how long did you take? You didn't just wake up from long COVID and say, today I feel gratitude, and you feel better tomorrow. Of course not.
No.
So it takes a long time. I'm still trying. You know, I had a slip disc in L4, L5 when I was 21 years old in a stupid basketball accident, and sometimes it hurts me. But I'm still trying. I'm still living with that. And I still, when all the ducks line up in a row and I'm not behaving well, I get a back pain. So I still need to deal with it. So all of us are given challenges in life. And this long COVID has given a lot more people challenges in a short time. But we need to evolve. And in our evolution of thought, spirit, and mindset, we can heal, right? And of course, you know, I'm not saying this for everyone, but there are some red flags that may mean you need to really seek medical attention. I hope we have time to cover that. But this capacity for healing within yourself is there, and it's more powerful than you think it is.
And actually, we've just not been brought up in our generations to think about this. When you're poorly, you go to a doctor, and we've had all of our own natural innate ability sort of stripped away from us. We've been sort of uneducated about that, which is why it's a really big challenge, I think, to get to a point where you're really ill and start to re-educate yourself about what you can do to help yourself. Yeah, oh God, this is huge. I mean, it's so big. And I think we've touched on this a bit last time when we went, God, it's so big, we could talk about this for hours.
And the other thing to say is we're not saying in any way that it is easy, or that, you know, that Boon and I haven't had COVID or long COVID, so we don't understand what it is like. So it is a very difficult situation, and everybody is different. But understanding the effects that what we were talking about, stress and modern living, can have on the body is great for unlocking and realizing the power of you and your body to heal as well. So it is difficult. No one's the same. Sometimes it will be an unpredictable course, but there is also light at the end of the tunnel for getting better.
I think that's the thing. So whilst I still will have symptoms, I tend to declare myself having recovered, because I just think it's a nicer way of thinking about myself. But yeah, you know, and so when I do get sick or pulled down by it, I just go, oh, it's just, you know, oh, it's just a symptom coming back. Anyway, we have questions.
I know we could go on forever, right? And ignore the questions till the next series. But yeah,
okay.
Please crack on.
I'm going to crack on. Many people still can't exercise without shortness of breath, despite doing the breathing exercises, gentle yoga, diet changes, etc. How patient do some people have to be with this? I mean,
So
what
the journey
timeframe
of
are we looking at?
journey of recovery comes in a stepwise manner in these syndromes, and that means you take 3 or 4 steps forward, and you might take 3 or 4 steps back, or 2 or 3 steps back. And the key thing is maybe to recognize or diarize the fact that you are generally getting better. And maybe the gratitude exercise that I would like everyone to do is that every morning when you wake up, you say, it's a partly gratitude, partly manifestation, but every day in every way, I'm getting better and better. And that is what you say. And if you do feel it and you do believe it, then you know what? Your mindset will shift and you will get better. So the fact that you have fear about the future by asking this question, as in, what if I have a relapse, means that your mindset is really not shifted. Even if you have a relapse, the awareness about the reasons for your relapse, or the awareness that, look, a relapse has happened, and so I'm just going to stick with the plan, go with the flow, go with the advice that has been given. And bear in mind, last week we covered all the physical maneuvers, right? So I'm not saying you can mentally get yourself into wellness without drinking, without being aware of your blood pressure, salting, compression. All these other things still need to be done, but you need to be aware that the journey of recovery can be fraught with hurdles. Just like in life, you have many hurdles. And you know what? Be more resilient and actually be more positive about the fact that you can overcome. This too shall pass, and you will overcome this next hurdle and get to be a better place.
Great.
And the answer is you have to be very patient with yourself. Again, everybody is different, and you might see other people in the group or other people in your that you know getting better, and you feel that you aren't. But you have to take your own pace and take the pace of your body. And different, you know, you might find that you're still struggling to exercise, and then you'll have improvements unexpectedly at some point. The key with exercise and pacing yourself is the worst thing that you can do is overdo it. And a lot of the people, as we were talking about last week, who get long COVID were quite high functioning. You know, interestingly, a lot of people who are very fit, who do a lot of exercise, who are athletes. And if you expect to be able to go back to that too soon, or even after months, then you can exhaust yourself and actually set yourself back quite significantly. And it's very difficult if you're very fit to then have to say, right, the only exercise I'm going to do today is some deep breathing on a mat lying down. But the key is just very, very gradual increments. And obviously Susie is your leader there.
The leader. I don't know if I describe myself as that. Well, that's great, because actually that's going to lead us beautifully into the next subject, which is HRV, heart rate variability. Now, I know lots of us have got our trackers on, right? And we're checking our body batteries and we're looking at our heart rate variability, and it is beginning to help some people, particularly me, actually. So I've got this one that has, I don't want to use the brand, but it tells me, you know, oh, actually, just because you had what you thought was 7 hours sleep, only 50 minutes of that was deep. And actually, you only charged your battery to 20% today. And I go, oh, that's interesting. So it's teaching me that actually I might not be getting the rest that I need. And so I do need to pare back some of my exercise. How important is HRV and understanding HRV in the bigger picture of recovery? And I think we've already started to touch on it there. So Boon, why don't I come to you? Because I know HRV is your thing.
Thanks. I think in a way that the question is asked, how important is HRV and understanding HRV? I think HRV is a tool to guide us to trust the feeling that we're feeling when we're in a good coherent state. When I say coherence, I means that means your HRV is expressed to the extent that you have enough vagus. And just to clarify a concept, HRV stands for heart rate variability. And effectively, it is a number that is not your heart rate, to be clear. Yeah. If I have an average heart rate, for example, of 60 beats a minute, I can have a very low or a very high HRV. You don't know that until I do this next exercise, which is I take a deep breath in and I take a deep breath out. And on the breath in, if my heart rate goes from 60 to 61, And when I breathe out, it goes from 61 to 59. And then I in and out again from 61 to 59. Then technically I've had 1 beats per minute difference in HRV, i.e. I'm oscillating around the 60 mark, but only by 1 point up and 1 point down. That is a bad HRV. So the good HRV is when you're at 60, for example, it could be 80, it could be 100, whatever it is. But when you breathe in, your heart rate goes to 80, for example. When you breathe out, it goes to 40. And this oscillations between 80 and 40 in a cyclical pattern coupled to your breath is called respiratory sinus arrhythmia, because your heart rate is directly influenced by the vagus nerve through breath. And so the breathing entrainment of HRV is what characterizes that value. So just to clarify, that is what HRV means. And it's not your heart rate itself. It is the variation in the top and the bottom of heart rate. Now, I don't know, I've got my kit prepared. I could show you very briefly and Mel could talk through. Would you like me to do that for 3 minutes?
Yes, please. Yes, please.
Mel, ready?
Yeah. So what Boon is about to do now is he's going to use something called a biofeedback device. And essentially what that is, you see him connecting himself up. So he's putting something on his ear, which is measuring his heart rate. And by measuring his heart rate, it will also measure his heart rate variability, because it will detect the changes beat to beat in heart rate. And then by Bluetooth on his mobile phone, he's going to have an app. And on that app, it's going to be able to show him exactly what his heart rate variability is. He'll show us when he shares his screen, because he'll have the app on his computer as well, a breathing pacer. And then I'll talk through what he shows. But what we know is that if you breathe, so here we go. So we've got his, so you can see his pulse. So his current heart rate is 78 beats per minute. And that is you can see his pulse kind of beating there. The top graph that you're seeing is for every heartbeat, it's just measuring the difference in the heartbeat. So every time his heart beats, it's measuring the difference in his heart in milliseconds between one beat and the other in his heart rate variability. Now, what we know is that if you're breathing at 6 breaths per minute, so that is 10 seconds in and 10 seconds out, so a long inhalation, a hold, a long exhalation and hold, you can actually influence your heart rate and your heart rate variability, because you're influencing the amount that your heart increases or accelerates on inspiration, and then the amount that it decelerates on exhalation. And if you're doing this very regularly through a breathing pacer, and you can see on the right, he's got this breathing pacer, the rectangles of blue going up and down, then you can regulate and you can kind of harmonize your heart rate. So you're controlling the heart rate inhalation and the heart rate exhalation. The heart rate going up on inhalation and the heart rate going down on exhalation. Now, at the moment, he's just started. So he's just kind of getting it regular. And you can see it's a bit sort of jiggly. The top line, it looks a bit irregular and chaotic. And that is the sign of somebody who's just started, or someone who's talking, or perhaps someone who's thinking about their breakfast or the train that they have to catch in 20 minutes, because it's all over the place. And actually what you want to do, as you can see now, he's taken a couple of big breaths, and already that pattern is starting to become regular. And when you get your breathing into a very regular pattern, that heart rate variability trace starts to become very smooth in what we describe as a sine wave. And at that point, you know that your breathing and your heart rate are aligned completely. And that's the point of maximum physiological efficiency, because it's the point at which your gas exchange in your lungs is going to be optimized. So it's 6 breaths a minute. The onset of your breathing in is correlating with the oxygen going into your lungs, and the onset of your breathing out is correlating with the deoxygenated blood. And then this score he's got on the bottom left, the coherence. So that is an equation, and it basically reflects how much time you're spending in a state of that alignment between your heart rate, between your breathing, and between your kind of all of your body systems. And the higher your coherence score, the better. So Boon is very good at this exercise, and this often comes with practicing, and it comes. And the other thing that's very important in this, which we're not showing, is that you can actually upload either a mandala or a breath pacer, or pictures that are going to instill feelings of gratitude, hope, love. If you think about a loved one or somebody that's very important. So it's very important to have those cortical, so the brain, the thoughts that are also influencing your vagus nerve. As we were hearing earlier, the vagus nerve directly innervates part of the brain that's responsible for gratitude and good thoughts. So you can actually influence your mind. So the coherence scores are being shown. It's a good idea when you're doing, so you can do an exercise like this for a couple of minutes. You use the breath pacer, you see what your heart rate is and your heart rate variability, and you can get an idea over time. And with practicing this, so practicing breathing in and out, aiming for a frequency that suits you, but they normally say about 6 breaths per minute is good. And then you can see what your scores are. Now, as we were mentioning with Fitbits and with everything else, you don't want to become obsessed with this, because the minute you start looking at your coherence score and you start looking at your heart rate variability, then you get stressed and your scores go kind of all over the place. But if you can use it as a marker and an idea of how adaptable your system is and how kind of resilient your system is, that it's able to switch and to your heart rate to go up when you're breathing in and down when you're breathing out, that's a sign of a healthy autonomic nervous system. And in response to the question that you asked, it is very important in looking for recovery. So we know from scientific studies that actually if you've got a high heart rate variability, so if it goes high, as Boon was saying, so up to 65, 70 on inhalation, down to 45, 50 on exhalation, lots of markers, even of survival, are higher. So patients who've had a heart attack, if they've got a higher heart rate variability, their survival is going to be better than a lower heart rate variability. And so it's often used in scientific studies as a marker of health. That's to say that the heart rate variability shown, even on, this is the good thing about this biofeedback device, is that you're going to be doing it at a certain time every day when you're relaxed, perhaps after you've woken up, when your body is relaxed, and you can measure it time over time. And it's often just looking at the differences time over time that's more important than the values per se. If it's on your watch, it may not be always completely accurate. So again, chasing that number is much less useful, but being aware of it as a concept is very important. Is there anything on that screen, Susie, that doesn't make sense? Just so again, you see his heart rate variability at the top, and that's the sine wave that you're kind of aiming for. You can normally get it very, very smooth, but I think under pressure on the camera, it's less kind of sine-like. Then you've got the coherence score at the bottom left, and then just a kind of breakdown of your scores on the bottom right.
Yeah, no, I think it all makes complete sense. Yeah, I know that a lot of people started, because we talked about it in the group, a lot of people started to do a heart rate variability check using the Watson Blue app, which was a free app that you could download. I think it was devised for professional sports training. And you just do a check-in with a pulse on a light every morning, and it kind of gives you start to build up a pattern around it, which was really useful for a lot of people, definitely.
Yeah, the pattern is important. Yeah.
So I was going to say with this trace, just so that people understand, there are two things here. I did an upgrade of this just before we came on this. When I turned on this app on my laptop, it did an upgrade. And so the breath pacer here wasn't as good as it normally is, because I couldn't track the bottom of the breath pacer. The other thing that I had done that I forgot how to switch off is it was playing music that you couldn't hear. And the music and the breath pacer wasn't in coherence. And then the third thing was I was listening to Mel's voice in the background. So there are three components that have made my mind very agitated. And I would say that this is reflected. So it's wonderful that I can't demonstrate a very nice, stable, coherent pattern. If I say there was a coherent pattern, it was here. Just these 2 cycles here.
Yeah.
And it's going to the third. And then I got distracted by the music and the breath pacer. So at this level of coherence at about 4 minutes, look, my coherence shot up to very high. And normally, if I'm not distractible, I can make this pattern continuously form like this. But just so you know what you're looking at, this is a heart rate of 65, let's say. pushing all the way up to say 85. So my band of variability is between 65 to 85, and that is what heart rate variability is. And when you're not in a coherent state, like at the start, can you see how it is just kind of all over the place? It goes up and down in a non-sinusoidal, non-regular pattern.
Yeah.
And that is when your coherence is very low. Towards the end, it's also like this. As I was going to take myself off, we've lost that coherent pattern. And so I stopped the recording.
Mm.
But this is, so I just stopped sharing my screen. But in answer to the question, it is helpful when I'm feeling this state to know in a biofeedback sense how I feel.
Yeah.
But to be honest, if you can get to this state without a biofeedback tool and you know you're coherent, or you know that you've got this heart rate variability, regular breath pattern, then that feeling itself should be something you learn to become aware of.
Yeah.
And you become less and less reliant on your HRV sensors, right? So this is biofeedback training, which is very useful at the beginning of your journey when you don't know what it feels like. To get into the groove, to feel it at a coherence of, say, anything above 1 is pretty good. So if your coherence is 2 to start off with, or 1.2, then work your way up. And if you can get to a level of 4, breathing for 10 minutes, always above 4, I would say your nervous system is quite synchronized in a very nice way. So it could be a good way to train.
Great.
And yeah, this is not, by the way, this is the laptop version, which is called the EM Wave Pro. You won't get this. You don't need to get this. You can get the one that is called the Inner Balance, which just links to your iPhone or Android. It's a much easier system, but because we are on a laptop today, I thought I'd just show it on the laptop. Yeah.
Great. Thank you. Thank you for that demo. That's really helpful, I think, because a lot of people are going, okay, so we're doing this HRV tracking and we're getting, but what does the information even mean? I think we're now beginning to help unpack that for a lot of people. So here's the next question, which sort of links to this. With the reintroduction of exercise, should we be working to keep our heart rates below a certain threshold? Many of us use trackers, but we're also aware that becoming obsessed with this data can cause anxiety. How do we find the right balance?
Mel, do you want to take that? Or
Yeah, so it's a very good question. And it sort of touched on what we were saying before, is that actually, I think when you're exercising, do what feels good and do what feels right. So especially in these early stages, you want to be exercising at a way that you're not feeling as if you're exerting yourself. So exercising inside a sort of envelope of comfort that you're able to regulate. If you start to feel unwell, then that's when to stop and to pace it back. I would probably say when you're exercising, don't look at your heart rate monitor, because then that can get you into a vicious cycle of then worrying about it. If you do notice that your heart is racing and it's starting to make you feel unwell, then it might be a sign that you are overdoing it, and to go back a level. But I wouldn't say, I don't know, Boon, what do you think about aiming for a certain level not to exceed?
no, I think the key thing about exercise is if you're in a standing position and you're already feeling palpitations and your heart rate is already at a level that is, let's say, 75% of your target heart rate. And so to be clear to your group, the target heart rate is a very simple formula. It's 220 minus your age. So for example, if you're 40 years old, your maximum target heart rate should be 220 minus 40 equals 180. And we would like you generally to push in the aerobic threshold of between, let's say, 60 to 75% of your target heart rate when you're exercising. So for that, it's 80% of 180, whatever that number is. Is it 164 or something like that? Maybe you can work it out. And if you're already standing and achieving that heart rate, which is quite high, then you know you haven't got that much more to give, if you see what I mean. So it is helpful to allow you to see how close to your maximum target threshold you are already at. And some patients find that on minimal exertion, they really push up to that maximum target heart rate. And I wouldn't go any further than that. In fact, I would probably stick at 80% of target heart rate. And so you might find that you get more activity done, you get more muscular work active when you are lying in a recumbent position and exercising, or pedaling on an exercise bike against resistance while seated on a chair. So you don't have to fight gravity. So going for a walk or cross trainer are upright activities, and you have to fight gravity. And that fighting of gravity is what already leads to your tachycardia to start off with in the first instance.
When people start class with me, what I tend to recommend is stop before you even remotely feel like you've done enough. I want people, you know, in the first 2 weeks, I say do as little as is physically possible. And then let's take that as your base threshold. And then we just build from there. So at no point are you going to be overexerting, because I don't want people to risk that overexert, because what we know is the post-exertional malaise can be devastating because it can throw people back a couple of weeks. So, you know, my advice is if you're going to start exercising, do a really small amount and quit before you feel like you need to quit. And then build from there. And then that way you're doing a really beautiful kind of, you know, it's the hare and the tortoise, isn't it? You know, you're just going to gently, gently take it along. You're not going to dart to the end and collapse just before the finish line.
Exactly. And those increments, and I'm sure, Susie, I mean, you could talk much more than us, but it should be very gradual and very cautious.
Yeah.
And I guess that must be the biggest thing, is to fight the urge to say, well, you know, before COVID, I was able to do a half marathon. I'm going to try my luck. Yeah.
I think it's really frustrating for people, especially when I go on and on about it. Yes. You know, I know who you were, but that's not who you are right now. And we're creating something new. So, you know, it's trust the process.
Exactly.
Great. Okay. We're going to move on to medication. So last time we talked about ivabradine, and this time I want us to talk about metaprolone. Can you tell us the difference between the two? And is it normal, if you're taking it, to still have heart irregularity, like heavy thirds and flip-flops and all of the usual kind of heart stuff that people can get quite scared by? So, Boon, I'm going to come to you for that one.
Sure. Ivabradine is a very, very selective drug. It only acts on two areas in the body. One is the retinal cells, and it might give you a meteor flashing phosphine side effect, like a flashing light at the corner of your vision. Not harmful. You won't lose your vision, but can be quite disconcerting. But the other place that it acts on is your sinus node. The sinus node is your natural pacemaker that sits in the right atrial chamber. And so ivabradine lowers the intrinsic firing rate within the sinus node. So that's how it works in combating tachycardia. Now, metoprolol is a beta blocker. It blocks the beta adrenaline receptor on all areas of the body, but also available for it on the sinus node and the AV node. So the beta blocker, if you like, is an anti-adrenaline drug. And if you think about it, the way our sinus node or natural pacemaker picks up its rate and goes faster is through adrenaline. And so the adrenaline sits on a receptor, which takes it, and then it causes the heart to beat faster. So the beta blocker blocks that receptor and prevents the heart from beating faster that way. But a beta blocker is more dirty because it also acts on other components and other receptors in your body. And one of the downsides is that a beta blocker can lower your blood pressure as well. So if you start off with a low blood pressure and because of your low blood pressure, you're getting tachycardia, and you take a beta blocker that can combat the tachycardia, but will lower your blood pressure more, guess what? The likelihood is that you will feel more unwell.
Yeah.
When you still have the drive of the tachycardia. So if somebody has a very low blood pressure, then you would avoid a beta blocker. The only beta blocker that I normally prescribe in patients who have a normal or high normal blood pressure with tachycardia is, and that those two things tell me that the patients have too much adrenaline, hyper-expressing adrenaline with no low blood pressure states, then I can give propranolol, which is a much shorter acting global drug, and that normally is given at a low dose of 10 milligrams twice a day. So that is the beta blocker that I would typically use if I need to use it to help with the tachycardia.
And if someone does have a very low BP, does that basically mean that there is not a drug that can help them with this tachycardia?
There's a very important drug. It's called water, H2O. And the other very important drug is called salt, sodium chloride. And the other important drug is called compression. So all these are, they say non-pharmacologic ways to deal with low BP states. But in my opinion, it's the most important way to deal with low BP states. Now, what you're alluding to, I guess, is whether there is a specific drug that can be taken to augment or improve blood pressure. And there are two that we prescribe commonly. One is called midodrine. Now, unlike a beta blocker, this is an agonist, something that makes the adrenaline effect stronger, is called an agonist. So there's an alpha agonist. So the adrenaline molecule it's very strange and odd, but there's alpha and beta. The beta blockers are the ones that are present in the heart and lungs. The alpha receptors are present in your blood vessels. So we give the alpha agonist, the opposite of a blocker, to make the blood vessels squeeze and push the blood back up from the splanchnic or the gut bed and the lower limbs back into the heart, so that the heart has enough expansion in volume to generate more blood pressure. And that would be my top drug, which is midodrine, MIDODRINE, 2.5 milligrams TDS. The other drug is called fludrocortisone. It's a very weak steroid. It's also known as a mineralocorticoid, and that acts at the level of kidneys to reabsorb sodium. So you're not losing so much salt, and you retain salt. And with the retention of salt, you retain fluid, and so you expand your plasma volume, or the amount of blood circulating around, and that can also help with low blood pressure states.
But it is, and I'm hearing you stressing this, it is important that they're doing the other stuff, the compression garments, the fluid, the salt, all of that. It has to, it's not just, if you take this tablet, you don't need to do these things. It's not like that. Great. Okay. Someone asked here, I have a sense that we already know the answer. Do we have to wait for a cardiologist appointment to be prescribed these medications, or can a GP do it?
I think most GPs would be generally reluctant to prescribe these medications because they are potentially not so familiar with this low blood pressure syndromes.
Yeah.
By and large, the majority of the population are given antihypertensive drugs, which is drugs to lower blood pressure, because the majority of the population have high blood pressure. Now, for a GP to then go against the grain when they're not familiar with this, it is quite unusual. So don't go looking, I guess, so quickly for the solution in a drug. We come back to what we said the whole of this last 45 minutes, which is look for the answer within, and look to do the physical strategies first. And if you're really struggling, and if you very usefully buy yourself an upper arm blood pressure cuff, and particularly if your resting blood pressures are typically below 110 systolic, which is the high value, and if you stand up and it drops typically to below 100 systolic, and you feel the onset of symptoms whenever you stand up, despite doing your fluid salt compression, that is the point at which perhaps you should see your GP and ask if they would be comfortable prescribing you something to augment your blood pressure. Most of them will say no. And then it's a question of, using your local resource to get to see the right person. And here I have to be very guarded, Mel, because I'm just very aware that even cardiologists and other specialists who are not so familiar with low blood pressure states may be reluctant to prescribe this. So it's a very a challenging situation where there are very few people who know or are confident prescribing. So one top tip is go to the STARS website, and I'll put a link, I'll send Susie a link, and look for experts in POTS or syncope, and those are the local people that you can see to try and get some help with the low blood pressure dysautonomic states.
Great. That's really great advice. What I don't want people starting to do is Googling these particular medications that they can then get from Amazon in India or something. Let's not go there, guys.
Yeah, absolutely, because it has to be prescribed very carefully.
Yeah. And what I do know is that a lot of people do have, as a result of COVID, very low BP. So I know mine was very low. And my doctor never took my blood pressure and put me on beta blockers. And after about 3 days, I went, that doesn't feel any better. In fact, I think I feel worse. So I'll stop taking them now. Thank you very much. So I think, the level of understanding, I think at GP level is, not at the level at which we are talking here, which why people do need to get themselves on a waiting list to see a cardiologist if that's what you need to do. I'm going to move on to...
I'm not even sure that's true. I mean, I think the level of understanding amongst everyone, us included, we might know a bit about autonomic dysfunction, but I still acknowledge, and Mel does, that we still don't know a lot about this stuff. I think what is challenging particularly is the openness, I guess. And so long as people have an open mindset, when I say open mindset, I mean us, Susie, not you, not patients. But this is the other technical challenge, which the logistical challenge of spreading the word and educating our colleagues. That is also proving slightly challenging because everyone has a busy job, Susie. You can imagine, and who wants to learn about this whole new disease process? Because you don't need to. You're busy enough in your own world. Why pick up something new? So that is a challenge. And so even if you saw a cardiologist, I would say, don't be put off by somebody who may not know as much as you do. So it's a very important thing, right? Because you go and see this person who you think will have all the answers and they don't. How does that make you feel? You come away and you can either feel disempowered or feel frustrated or angry, and it feels the cycle. And you feel angry at the system because they can't fix me, they can't help me. Whereas in fact, if you spin it on its head and say, look, I forgive them, or I express gratitude because I've had this experience, and I know it sounds strange, but the experience has taught me that I need a bit more self-resilience. I need to learn and educate myself and believe in myself and these principles of tackling this disease process by myself. And learn to take the measures that some of which we've communicated today. Now, I realize this is quite provocative, and probably Mel always is very good in stopping me when I go too far, I guess. But there is a balance to be had, right? And in my practice day to day, I see so many patients who've had cycles of consultants going around in circles, and then when what they need is actually a consult like this, like what we've done for an hour to communicate education, expectation, hope, recovery. That's what is needed. But guess what? That is incompatible with a healthcare service that is now prescribing 8-minute consults plus 2 minutes for the dictation, or 20-minute consults in my clinic. It is very difficult, right? So how do we spread the word? We spread it through an avenue like this, what we're doing now. But the important thing is to allow your group to understand and to forgive the people who don't know, and that itself is a very healing process. Do you agree with that, Mel? Or?
Yeah, and I think yes, and on the theme of everything that we said is not putting all your hope in that drug, because actually often by the time people do come to our clinic, the ones who've been very compliant with the fluid, the salt, the compression stockings and the maneuvers actually don't need the medications. That's again not to say for everyone, but don't put all your hope in that drug, because actually there are lots and lots of things you can do before you see the specialist.
Absolutely. And I think we said that last week, didn't we? If you're beginning to recognize that those symptoms might be, that we're talking about might be what you're experiencing, start now looking after yourself in this way. Don't wait. I mean, I know I saw a cardiologist briefly for my 8-minute slot a while ago. And he said to me, I think you know more than I do. So actually, it was great. And I said, okay, so why don't I tell you a little bit more about what I know in general about the long COVID situation? So I basically helped him to understand a bit more about what people were experiencing en masse, and left feeling like I'd done my part. I've educated someone today. This is
That's
great.
Another point, actually, and it's a very good point, that this condition, we've only known, COVID was only named in February 2020. So it's been just over a year. And actually, we are all learning, doctors, patients, everyone, the research community. And a lot of this we have to learn from each other. So that's a really nice story.
Well, learning takes time, right? You have to take time off work to learn. And everyone's been so busy doing their jobs and firefighting this catastrophe that there's been learning only by experience. And to have these situations where we're getting to ask questions and compare thoughts, this is a really rare and precious moment, which is why, let me just remind the viewer, it's happening at 7:30 in the morning on a Sunday morning. So let's move on. I'm actually going to jump to the POTS questions before I pick up the female cycle question that we have here. So because it's linked to what we're talking about. So let's see if we can kind of quick fire through some of these, because again, they're picking up what we were talking about last week quite well. Do people with POTS tend to desaturate during the night? Some people were sharing that their saturation rate dropped to 87 to 90%. Is this normal?
Can I take that one, Mel? It's very important that you check your sensor. One of the ways in which your finger probe sensor may give an inaccurate reading is when your blood pressure is low and you don't have enough pulsatility in the finger. So if your sats are dropping in this finger and that finger, in your earlobe perhaps, and you feel very unwell with the air hunger and a visible shortness of breath, then I think something's not right, and it's likely to reflect lung pathology. But if you wake up and you're very breathless, at the beginning of this talk, we talk about the mast cell syndrome, but I guess a low blood pressure state with adrenaline activation. Guess what adrenaline does to your breathing rate? It makes it quicker because you're priming your lungs for running away from the saber-toothed cat. And so that breathlessness may well be this kind of deep yawning, sighing type breathing, the sensation that I can't get enough breath. That's a very typical description of a degree of dysfunctional breathing. Now, when you get up and about and move your blood pressure higher, if your saturations then come up, it could be just a misreading from the low blood pressure that is causing the artifactual reading. But if it's real and you are consistently desaturating, and importantly, if you confirm this by a 1 minute sit to stand test, that means you put your SATS probe on and you sit and stand on a chair like I'm sitting on as many times as you can in 1 minute. And that is kind of an aerobic style exercise, like doing squats. And if your SATs fall by more than 4%, then you're likely to have a lung pathology, i.e. that is a red flag. That's right, Mel? Yeah.
Yeah, so
that would be go get help.
Yeah, exactly. See your GP, because that could be the complications of the COVID on your lung.
Great.
Rather than the POTS or the long COVID, yeah.
And let me just say, a minute of getting up and down from a chair, you think that they have to do a minute? Because actually for some people that will cause them issues.
It's tough, but it's what is recommended in the long COVID clinics to assess for significant desaturations due to long COVID lung damage. But Mel, I don't know if you've had any more experience.
No, but I guess also with the population that we're considering here, where any sort of exercise, particularly standing up, might be exhausting, that might make you very unwell for the rest of the day, mightn't it? So perhaps, I mean, but simple things like measuring your oxygen levels when you walk to the toilet and back might be, and if it drops significantly.
Yeah, okay, great. Because I don't want people out there doing this 1 minute major test and then collapsing if they don't need to. But good that we raised it, and I think it is something that people can go away and look at more. Okay.
And also just monitoring your oxygen levels at rest as well can be helpful, because again, it should be over around 94-95%. If it's consistently below that, then again you think, well, that's not really related to the POTS or long COVID. There might be something in the lung that the doctor needs to know about.
So what I would also, and I didn't ask about what machinery they were using to check, what I know is that my tracker can tell me that my saturation goes down to something like 83 at night. So I ignore that, but it's on my wrist. So we are looking at measurements that come from that finger gripper device, don't we? Not something that you're wearing on your wrist, because I think that will give quite a different reading. Okay, good. Is it normal to feel really groggy in the morning, like you've got a hangover, and feel a bit more awake in the afternoon? Yeah, I think it is.
Yeah, so the simple answer is yes. The most dehydrated we'll ever be is when we first wake up, because we're producing urine all night, sweating under the sheets, evaporating, and not drinking water. So for that 8-hour period, you're not drinking, you're producing urine, you're losing respiration, insensible fluids. So it's like a hangover. And if you did have a glass of wine or a pint, then definitely, if you have long COVID, it's a no-no. And the tip here, if you're getting back to drinking, is that you chase down every unit of alcohol with a pint of water, please.
Yeah. Okay.
Right.
I think very few people are getting back to drinking,
Sure.
honest, because the body just cannot tolerate it.
Sure.
But great. Okay. Is a pulsating migraine linked to POTS? So it's pulsating pain through the face and a pressure through the neck and sternum, which sounds horrible. Is that POTS?
So the answer is likely yes, in my opinion. We see in our imperial syncope unit a lot of patients with migraine who've been sent through for tilt table testing, and I would say a third of them have a symptom of migraine triggered by the POTS-like phenomena on tilt table testing. A third of them have absolutely no link, and a third of them have genuine migraine, which is potentially not genuinely linked in to the hemodynamic state, but can occur at random times.
Okay.
And remembering that one of the commonest triggers for migraine is dehydration, and that, so same principles apply of drinking fluid.
Right. And stress as well.
Yeah, absolutely.
Yeah. Gosh, that stress. Okay. We can put a link into the write-up about what compression garments did you recommend last week. If we say it out loud, I can then also remember to write it in. Do you remember?
Yeah, so these are so daylong.co.uk, Sigvaris and Biofine are the kind of brands that we tend to get patients to self-purchase. So yeah, those would be the ones.
Because people are looking online and kind of coming up. Oh, there we go. Great, I can put that into the text. Okay, if someone has been following the recommended protocols for POTS, how long might it take for them to see a difference?
Open-ended question, and I guess the answer is from yeah, from 2 days to 3 months or 6 months. Okay. But if you're chronically dehydrated, then having increased your hydration within 24 hours, you should feel a massive difference. And that is the simplest win for somebody who's dehydrated. Now, if you're already very well hydrated and having salt, and you need a bit more work on the other components, then it typically takes a bit longer, and a trial of compression, and you know, the kind of mindset shift, the good sleeping habits that we talked about. Yeah.
And also the thing that really struck me last week about actually the detrimental effect of too much lying down. How that then starts to play into the narrative of the POTS experience. So the more people can become upright, sitting upright, because I've had quite a few people say, should I be lying down to work? No, the less lying down that you do, the more the body can start to regulate itself, right? So.
And again, if you find that even sitting up to work becomes absolutely exhausting, then again, pace yourself and say, right, today I'm going to try and sit up for 10 minutes, 7 minutes.
Tiny steps.
Exactly. But even if you are lying down, again, there are things that you can do. So employing some of the stuff that I'm sure you teach, which is the, stretching on the mat, or abdominal exercises as you're lying, leg exercises, just to keep your body moving.
Doing bridge pose in bed. Great. Lie on your back, push your bottom in the air. You're doing that thing of clenching your buttocks, but you're also elevating the hips, stimulating the blood pressure.
Absolutely.
Yeah. Okay, great.
Top tip for sitting at a desk if you have to work on Zoom calls all day is just get one of those not IKEA, but stools, like short stools that you'd give your 5-year-old boy to reach the toilet. And then you just step on the stool with one leg and another, and every time you raise one leg, you're returning a bit of that blood. So it's a free exercise that doesn't feel like an exercise. Yeah.
Great. Okay, that is a top tip. I might start doing that too. Do you recommend a noradrenaline test? So this woman met the POTS criteria. You're already shaking your head, I can tell without looking at you. Before starting on bisoprolol and now ivabradine. Should she assume dysautonomia or should she seek a tilt table test? The protocol isn't making much of a difference yet 1 month in.
The noradrenaline test is a tricky test. I've never done one, and I've run the imperial syncope unit for more than 10 years. So the answer is no. It's done in research settings to ascertain how much adrenaline is produced when you're tilted upright. But guess what? If I say to you that if your heart rate increases, the way your heart rate increases is through an adrenaline surge, you have a nice surrogate without the invasive blood test. So you don't need that to tell you the answer that you already know.
Yeah. So I suppose what we're hearing is she's saying, I've been doing the protocol for a month. It's not making a difference yet. We've already answered that question. Give it more time. Give it more time. Great. The thirst can be really extreme despite drinking nearly 3 to 4 liters a day, including salt tablets. I know this is linked to POTS, but what will help to regulate it? Might short-term IV therapy help with the debilitating fatigue that comes with this?
This is a tricky one. It's actually one of those guidelines within the Heart Rhythm Society that do suggest it's a reasonable alternative for somebody who's decompensating. I strongly disagree, just because if you then build a dependence on going into hospital to have an IV line each time, how many times do you want to go in a week, a day, a month? You know, you're going to run out of nice veins to cannulate, and then you're going to need a central line. To date, I know of maybe 2 or 3 patients who've gone on this journey, and it's always ended up badly because it doesn't solve the problem. And in fact, drinking with good stomach absorption of fluid is just as good. If your gut is working and you can drink, then please drink. You don't need to ask for IV fluids, because if the fluid is absorbed in the stomach and the small intestines, guess what? You are getting your IV fluid. It's just coming through your gut.
In the way that it's meant to, rather than through, because if anything going through the vein is always then has extra side effects and risks. The other thing is that if you are experiencing extreme thirst, there are other medical causes of thirst, and it's probably worth just making sure your doctor has done a blood sugar test, and various other things.
Yeah.
So flag that's the GP. You shouldn't really be getting extreme thirst if you're drinking that much fluid a day.
Well, that's what I thought, which is why I put the question in, because it's quite specific. 3 to 4 liters. It should be enough. You would like to think so, right? But yes, the blood sugar thing. And I do know some people whose pancreas has been affected by this, which is obviously going to play some role in affecting your blood sugar levels, and thirst will be one of those signs. Okay, great. If someone has all of the symptoms of POTS, but not the tachycardia, and we know it's not POTS, but should they follow the protocol anyway? Might that help?
So I guess I would caution by just getting people to buy a blood pressure monitor. So I favor the Omron M1 or M2. That's 35 to 40 pounds online or in Boots, and make sure that you have a blood pressure that's not high, that is on what I suspect will be between 100 and 125 systolic, then follow the protocol.
Yeah. Okay.
Because remember, as we were saying last week, there is that spectrum. So even if somebody doesn't fulfill the criteria for POTS, if you're getting a lot of symptoms when standing up, it suggests that you're part of a spectrum of what we call orthostatic intolerance.
Right. Great. Okay. Good. Should I be wearing compression tights at night in bed? Be quite hot. Which would make you more dehydrated.
No, you should not. And the one thing I didn't mention, and maybe Mel also, is that it could be helpful to try and exert some gravity at night by tilting the bed into this direction, head here, feet here, putting a couple of bricks at the bottom of your foot of the bed, legs. And it's a very complex physiological explanation to do with astronauts, but we covered this last week, right? Did we talk about astronauts last week?
I think so.
Yes, I think we might have. But anyway, watch the video last week on astronauts. And essentially what you're doing at night is to tilt train. When you tilt train and you lower the blood pressure, what you're doing is you're forcing the kidneys to reabsorb more sodium in a complex process called the renin-angiotensin-aldosterone hormonal system. And when you tilt train a lot, it's just like sitting up in the daytime. You are for free and getting more plasma volume over a period of weeks or months, because you're getting more of the intrinsic fludrocortisone. Fludrocortisone, you remember, is a drug we talked about to expand your plasma volume. Well, guess what? You can expand your own plasma volume by sleeping a bit more upright, like that. Okay.
Oh, that's great.
So that's a top tip too.
Tip 3.
Yeah.
Love that. Okay, great. Suddenly everyone's going to be running into their back gardens and looking for a brick to stick under their bed legs. Okay, so we're going to move on from POTS now. We're going to pick up the effect on the female cycle. You are probably aware that many women are experiencing changes in their cycle and an exacerbation of symptoms around their period. So I know for me, I would notice last year that I would have huge relapse of all my symptoms and feel absolutely sort of broken as I got my period, and I started to notice a pattern in it. So some postmenopausal women have started bleeding again, which I think has been quite disturbing and confusing. Others have had continuous bleeds or irregular cycles. All say their symptoms get worse around the onset of their period. Tell us how their autonomic nervous system might be impacting this. And I know, Mel, you said you'd pick this one up, so let's come to you.
Yes, the first thing to say is that it has been reported very commonly, so around COVID. And also, interestingly, this week, there was a lot in the news about after the vaccine is causing changes in menstrual cycle and menstrual patterns. We know that stress is one of the as always, stress that we've talked about for this session and last is one of the strongest sort of impactors on the menstrual cycle, and therefore you can have irregularities or changes to your cycle or changes to the kind of how heavy your period is if you're stressed, if you're medically unwell, or for various other kind of medical causes. So again, things like your thyroid, just make sure they're checked because that can impact on it. We know also that symptoms of dysautonomia can get worse around the time of your period. So the hormonal changes around your menstrual cycle can affect the autonomic nervous system. So can cause things, can cause a bit of an imbalance in your parasympathetic nervous system or vagal system. Often people may have worse palpitations or worse feelings of postural hypotension, and you can become more dehydrated. So that's the time really that you should be drinking more and complying and be particularly mindful of those conservative measures. The one thing to say though is that postmenopausal bleeding and bleeding between your periods and bleeding after sex, they are red flags. And so I wouldn't attribute that to COVID alone. And you should see your doctor and make sure that that's investigated properly because that can mean other things as well.
Definitely. So I know that I had constant bleeding for around 60 days and I had all of the checks and they came back completely clear and they just went, oh, there we go, unexplained.
Yes, yeah.
But which actually, you just have to be reassured by that. Because I know some people then go, oh, unexplained, but then what does it mean? And actually it does. And it's settled, my cycle has settled back into dead regular 26 days again, so it's fine.
And it usually, exactly, so it will settle. But I think if it is a change, and particularly bleeding between periods, after sex or definitely postmenopausal, you have to get those checks then. And then once they're normal, you can be reassured that this can just be changes to the cycle.
Susie, I have to sign off now. I'm very sorry. The meeting starts in 2 minutes.
I know. I looked at my watch and I went, oh, Boon needs to go.
Yeah. So thank you for having me. And
you are so welcome.
And can we just say that the questions are of such high quality that we're really impressed. And clearly this is a group of people who are very knowledgeable and very aware and very impressive. So thank you.
I'm sure the group will be flattered to hear your thoughts there because, you know, I think all of us are very much active in our own recovery journeys. But Mel, am I allowed to hang on to you for another 10 minutes just while we finish? There's one question in my final questions section. Can I grab 10 minutes for that?
Yes.
You can say no.
Maybe because they look like they might be Boon specific, so we could have one final session to cover them. Yeah.
Okay, there was just a couple of really meaty ones that I just thought we should at least acknowledge that they've come in, because they were such great questions. But we'll find it.
I'm actually, I don't know about you, Mel. I'm happy to come back, and if you gave feedback next week, I'm actually on call. I can't do, but maybe the following week, if you can kind of start to challenge us even more with even greater challenging questions, that makes life very exciting for me and Mel. Because before this Zoom consult, I was consulting with Mel and saying, wow, this really makes us think hard. And it's quite nice to be pushed to this level, quite nice intellectually for me and Mel to really prepare the answers as best as we can with an evidence base. So, it would be a pleasure to kind of meet again with even more questions, maybe in 2 or 3 weeks' time, if your group still has any to ask. Okay.
I think whilst you're offering, we'll take. Absolutely. Guys, thank you so much. I really, really appreciate it.
Have a good day.
Thank
Have
you.
A good day, Mel.
Have a great
Take
day.
care. Susie. Bye.